we will go ahead and get started to make sure that we have plenty of time to get through the information and answer any questions that any of you may have on this topic. We are recording this as well as we do with all of our office hour calls, and be able to put this on our website for future use, and you can revisit as many times as needed. So some quick introductions. I think I've talked to you, met some of you, or I had some office hour calls with you. Again, my name is Chad Hibbs. I'm the lead for strategic and community planning for the department underneath the Office of Quality Planning and Research. Really, my main position at this time is to help the boards through the development of the community assessment and plan, which we really had our partner with HPIO to help facilitate that process. We've gone through a lot of different iterations over the previous years with the community assessment and plan, but we hope that we built one now that has a solid infrastructure, and then any tweaks that we would need to make would not require wholesale changes moving forward. So there were a lot of changes from the previous assessments and plans to this one. One of those notably being the introduction of the exploration of equities and disparities throughout the assessment and the plan. This is something that Director Chris saw as a priority. This is a priority of the DeWine administration across all the Health and Human Services state departments. So really, we took the opportunity to address this topic in the assessment and plan for the very first time. And hopefully we'll be able to really be able to provide some data and analysis on where the potential for inequities and disparities may lie in the behavioral health system with the assistance of the boards and the department as a whole. So with this being a very new topic for the assessment and plan, we wanted to develop a bunch of resources as much as we could to help the boards through this process and really considering inequities and disparities in the planning process. So we asked our colleagues at HPIO, Amy and Haley, who I'll let them introduce themselves here in just a few minutes, to help us walk through what this could potentially look like, what this webinar could be, what resources would need to be included, what information needs to be included. They also worked with members of our diversity and cultural competency team within the department. So we had almost 10, 12 people working on this to help put this information and webinar together for your use today. So as I said, this is being recorded, and we'll have some time to get your questions answered at the end. Also at the end, we'll post in various locations, including email and in the chat function, a brief survey, evaluation survey, so we get some feedback on what you heard today and how you plan on using it. So without further ado, I will turn it over to Amy and Haley. Welcome, good afternoon, and thank you for helping us with this.
Absolutely. Thanks, everyone. Thanks, Chad, and thanks, everyone, for being with us today. Amy is sharing our slides here and is going to get us up and running. Like Chad mentioned, my name is Haley Aka. I'm joined by my colleague, Amy Bush-Stevens. We're both vice presidents at the Health Policy Institute of Ohio. And we are looking forward to spending this time with you, talking through all things equity in the community assessment and plan. You will hear us refer to the community assessment and plan as the CAP. If you have not memorized that acronym yet, that's what that means. And we do have a lot of material to cover with you all today, but we do want this to be responsive to any questions that you may have or thoughts that you're coming in with. So please use the chat box as a place to ask those questions, to add your comments. We'll be keeping an eye on that as we move through our material today. So as Chad mentioned, the Health Policy Institute of Ohio produced the community assessment and plan template under contract with OhioMHAS. And now we've also been contracted by the department to provide some technical assistance on the assessment and plan, including the information in this webinar. So here's our framework for the CAP. We call this our pathway to impact, and it takes us from services and programs in green on the left to the population level outcomes that we're working to address in red on the right. And you'll notice across the top in yellow, we have our cross-cutting priority, which is equity and cultural competence. The goal here, right, is to keep equity at the front and center of the assessment and plan so that our long-range impact can be achieved. And that long-range impact we see in the middle of the header on this image is that Ohio has a high-quality mental health and addiction prevention, treatment, and recovery system that is effective and valued by all Ohioans. In our next image here, you see how the CAP pathway to impact aligns with the OhioMHAS pathway to impact. This is the pathway to impact for the department. Equity is similarly called out in yellow as a cross-cutting priority. We see the very same long-range impact and vision for the department and the CAP assessment and plan, which shows us how partners across the state have some big picture shared goals, and that really collective action is needed to make this big picture vision a reality. So to get us started from a common understanding with these words that get thrown around, but maybe the definitions aren't quite clear, we're going to start with a few key terms today for some grounding. And we're going to start here with health equity, which I think is a logical starting place. So health equity is achieved when all Ohioans have the opportunity to attain their full health potential. Equity is the absence of socially unjust or unfair disparities in access to services, in the quality of services, and in our health and behavioral health outcomes. So this is the vision of the world that we're working toward, that we want to see. Another key word related to equity is health disparities. And you heard Chad mention this kind of simultaneously with equity, right? So disparities are those differences in the incidence, prevalence, mortality, burden of disease, or other conditions that exist among population groups. We know that we've not yet achieved equity because we have health disparities, and equity will be achieved when all disparities are eliminated. So we look at this quick example here, a graph that shows us depression prevalence. There were many examples I could have chosen, but I grabbed this one quick. Depression prevalence based on an individual's level of education and annual household income. And we see here that Ohioans who have lower educational attainment or lower incomes are more likely to have a depression diagnosis. These Ohioans are experiencing a disparity. Our next group of words are related to racism and discrimination. So discrimination describes any system that categorizes and ranks social groups and then distributes resources and opportunities differently across those groups based on the perceived inferior or superior ranking, right? And we see this across different types of categories, right? So a racist system ranks groups and distributes resources based on race. An ableist system does this based on disability status, ageism based on age, and on and on. There are many examples we could list. So we want to always be on the lookout, right, for how the systems that we're involved in are unfairly burdening or advantaging different groups of people. A very related term here is priority populations. Priority populations are groups of Ohioans that perform worse, experience worse outcomes than Ohioans overall. These groups may be unfairly burdened by these discriminatory systems, and they are experiencing disparities, right? They're priority populations because we're prioritizing programming and service delivery for these folks in order to eliminate those disparities and improve outcomes. And we can identify priority populations in a couple of different ways. We could do it through quantitative data. If you could go back to that last slide, Amy. We could do it through quantitative data, like Amy will be discussing later today. She's going to talk to us all about data disaggregation. We could also identify priority populations through quantitative data collection, like key informant interviews or focus group conversations. So now Amy's going to take us to our depression data example again, which shows us our disparities in depression prevalence by education and income. And here we see that Ohioans with less than a high school education and Ohioans with incomes below $35,000 per year perform worse than Ohio overall on depression, and so we can identify those groups as our priority populations. All right, next we have cultural competence. This is an important sort of foundation for program and service delivery. So, and it's a long one, so I'll piece through it a little bit. Cultural competence is a continuous learning process that results in an understanding and a respect for the unique beliefs, values, customs, languages, abilities, and traditions of all Ohioans. And once that understanding is built, we can develop policies and effectively run programs and services to better serve different groups of Ohioans. You may have also heard this term referred to as cultural humility. That word may be familiar to you. It's a very similar idea that acknowledges our own limitations in understanding the complex cultures of other groups of people. Related is linguistic competence, which is the ability to communicate effectively and convey information in a manner that's easily understood by diverse audiences, like people with limited English proficiency, those with low literacy skills, individuals with disabilities. This is another important consideration for service delivery, understanding how the people in our service area can best be communicated with. And our final terms that we'll look at are diversity and inclusion. And we include these because they're very commonly used, but their meanings and the activities that sort of fall in this category are sometimes fuzzy. So typically, we'll use diversity and inclusion to refer to an organization's sort of internal activities. So you see our definitions here that diversity from the source to illustrate this point is diversity is respect for and appreciation of differences that individuals bring to a workplace. Inclusion is creating a working culture and environment that recognizes and utilizes the perspectives of every employee. These words could also apply to collaborative work among organizations. It doesn't necessarily have to be just within one organization, but in general, when people are talking about diversity, equity, and inclusion or DEI committees, they're often referring to how an organization operates and if its employees are being valued and respected. That's very important, but it's different than the work of the CAP assessment and plan. The equity work in the CAP is to remove barriers and increase supports for the mental well-being and recovery of groups in the community experiencing the worst outcomes. So equity in our context is really focused on the external work of your boards in the communities that you serve. So speaking of the equity work that you'll be doing in your CAP, I want to mention just a few additional resources from OhioMHAS that may be relevant as you get started on this. You may be familiar with these before, but just want to highlight them again. First is the department's Diversity and Cultural Competency Strategic Plan. Some of us call it the DAC plan. And the DAC includes these 6 strategic goal areas, which may be helpful for you to consider as you work on your assessment and plan. You are certainly not required to align to the DAC. We can go to the next slide. But the DAC does include strategies and action steps that may be helpful for you, particularly as you're setting goals and choosing strategies to lift up in your plans. I'll also briefly mention the Health Equity and Cultural Competency Plan, also known as the HEC plan. If you received funding through this initiative, there may be some connections between that equity work and your community assessment and plan. Again, there's no requirement for alignment here, but we do recognize that there's a lot of activity related to health equity right now, and finding these connections between the different activities that you're working on may help you sort of streamline your work and keep you clear, right, on the goals that you're working to achieve and the outcomes that you want to see. So in that vein, I'll end our level setting here with this. We know that this work is challenging. Depending on your data access, disparities can be difficult to identify. And once you have identified them, they're even harder to address. We know also that different boards and communities are in different places when it comes to familiarity with equity work and that you're experiencing different barriers in your communities. I want you to know that we are in this work together, that not a single one of us is expected to solve these problems alone. The OhioMHAS and the HPIO teams are here to support you in this challenging and important work. You have each other as a resource as you move through this. And partners across the state have a role to play in lifting up these priority populations and addressing the disparities and inequities that we see. And what we know to be true is that little by little, with all of us working together, we can achieve our big picture goals, right? We know that we can achieve high quality service delivery across the continuum of care for every Ohioan in our state. So we'll end the level setting there. I'll check the chat box for questions, but Amy, I think you can move forward into your next section.
All right. Good afternoon, everyone. It looks like there was one question about what DAC stands for, and it's diversity and cultural competence, right? Okay.
That is correct.
Okay.
I'm sorry, I had a question in there as well. Maybe it didn't come through. This is David. I'm looking for some ideas, since many of the concepts and ideas you just laid out there are highly controversial in communities. There's not a lot of agreement on many of the things that you said. So as you go through this, please give us some ideas on how boards might negotiate communities where there's not a lot of agreement on many of the things you just said.
Yeah, that's a really good point, David. And as we go through, we'll give a variety of examples of how you can apply equity in the assessment and plan. And hopefully those examples will help with the the idea that equity is going to look different in different communities. There are different kinds of groups that are experiencing worse outcomes. And it's much broader than only race and ethnicity. There are many different forms of discrimination and different types of disparities. And so hopefully the content that we cover today will help with that. And if not, and if you still need, feel like some additional guidance would be helpful, we can definitely think about that. And we'll be asking for your suggestions in that survey on like additional content, because we are going to be doing some fact sheets and some additional webinars. So please let us know.
And I would just say at the onset here, in response to that, and in general, as we think about this work, we went through that list of key terms because those are words that are thrown around related to this topic, and it's helpful to get clear on what they each mean. But that doesn't mean that any single one of them needs to be used by you if it's not a helpful word to get at the outcomes that you want to see, right? So if discrimination is not a helpful word and you just want to talk about differences in outcomes and how we can move, progress for our communities that need it most, I think there's different language that can be used to get at these same concepts that can be really helpful when not everyone agrees that the language can be triggering.
That's helpful, Haley, to hear you say that, because of our national debate, a lot of these terms have become very charged. So, right, if knowing that we have some flexibility in the language we use is very helpful.
Yep, this was to lay it out for us to have a common understanding of what these words mean. You don't have to use any single one of them in the plan. We talk about priority populations in the plan, but otherwise you can communicate the way that you need to communicate.
Make it your own, make it fit for your community. All right, so I am going to get into the CAP template. Hopefully everyone has had a chance to look at those documents. I'm going to start with the assessment template. And these are some considerations for how to embed equity throughout the assessment process. And certainly no one is expecting that you can do all of these things perfectly, in this current assessment, but these are components to build towards over time. So these are ways that you can incorporate equity as you engage with community members and partners, as you collect data, and as you use the results from your assessment. So in this first category of engagement, this is about bringing together a broad range of partners throughout the phases of your assessment. So the planning phase, the data collection phase, interpreting the results, presenting the findings, and making sure that your meetings or your events are accessible for folks in the community. You know, things like time of day, locations, remote options, and languages. And I know all of you think about these things in the work that you do with your community partners. The second piece here is about inclusive decision making in the planning process for your assessment. So thinking about engaging different folks in the community, not just as a focus group participant or filling out a survey, but really in some of the decision making along the way. So really kind of sharing some power with different partners in the community, which can be challenging and take more time, but again, is something to build to over time. In the data collection bucket, in terms of equity, we talk about collecting, sharing, and using disaggregated data. So breaking data out into categories that are useful in your community. That could be race and ethnicity, that could be sex, it could be age, veteran status, many different ways you can break out your data. And then being creative to fill in some of the gaps, because we know we don't have all of the disaggregated data that we wish we had to do this work. And so we need to think about pulling in some qualitative methods, and I'll talk more about that in a little bit. Thinking about oversampling when we do surveys to make sure that we have adequate numbers for certain groups. So there are things that we can do to fill in those gaps that you will certainly find as you do this work. And then also exploring the root causes of disparities. So asking questions about what's driving the disparities you see in your community. And this will bring you upstream and can help you to be more effective in reducing disparities if there's a good understanding of what's driving those disparities. And then the third bucket here is using the assessment data. So really highlighting strengths, challenges, and disparities, flagging those key findings and disparities, but also talking about strengths and assets. So not everything is negative. And then sharing findings back with the community. And that could be, posting it on your website or using social media or whatever dissemination tools work for you. But really, showing the community that you gave us information. Here's how we're summarizing it. Here's how we're using it in our planning work. This is an example of what this can look like. This is from the ADAM board in Franklin County, and they actually have an online interactive data dashboards. It's pretty fancy. You don't have to be this fancy when communicating assessment data, but I thought this was a nice example of displaying disaggregated data. So here they're showing unmet needs that were identified through their assessment. And then if you hover over each of the unmet need areas, it pops up some bar charts that show some disaggregated data. So just an example of how to display disparities data that, of course, is going to look different in different communities. And then here's an example of how they're using that information to then guide their planning activities. So here they say, based on survey, focus group, and interview data, so they're using multiple sources in their assessment, they've identified the areas of unmet need across the continuum of care by different groups and who needs the most. And so this can then guide their planning activities to address what they found in the assessment. So that's kind of the idea of where we're headed. But of course, understanding that, the idea of an assessment is to paint a picture of the community. It's big and broad. A plan is more prioritized and narrow and says, this is what we're going to do. You're not required to address every need identified in your assessment. It's, totally normal that you would have a much broader set of unmet needs and challenges and disparities identified in your assessment than what's addressed in your plan. So looking at the template, the assessment template, there are basically 3 questions about disparities. So they address mental health and addiction challenges, service gaps and access challenges, and then social determinants of health. Here's what this question looks like. The first question looks like in the template. So it's asking you, based on your assessment findings, what disparities are you seeing? And it gives you this long list of groups to choose from. There are many different groups that experience disparities, and this obviously varies by community, and there's always the option to choose other specify. And that question is referring back to this matrix where it asked you about the top 3 challenges in your community. And so probably the easiest way to address this would be to think about what are those top 3 challenges in your community, and then which groups are experiencing the worst outcomes for those top 3 challenges. You could do it more broadly if you want, but that would be a more concise way to address it. Then we get to the question about service gaps and access challenges, and this follows a similar format. Oh, I was going to give an example here. If you, for example, identified adverse childhood experiences as something in your assessment that's a challenge in your community, you might then identify people with low incomes as a disparity group for that if you know that you're seeing ACEs being more common among children in poverty. All right, so that's the access gaps. And then the last one gets at social determinants of health. And so it is referring to this set of questions about social determinant of health factors in your community. Again, you have this top 3 column. And so identifying the groups that are most affected by those challenges in community conditions. So that's what that looks like. So the question is, how do you know how to answer those questions, right? How do you know what the groups are in your community that are experiencing the greatest challenges? Well, through your assessment, there are many different types of data that you can use, and I know many of you are already using all of these types of data in your work. So here are two key terms to keep in mind: quantitative and qualitative. So quantitative data is answering questions like how many, how much, how often. It's usually expressed in numbers, so think tables, bar charts, line graphs. Qualitative data is answering questions like why and how, and usually it's going to be shared in terms of like narrative, descriptions, common themes, things like that. Then we have primary and secondary data. Primary data just means you collect it yourself. Secondary data means you're getting it from some other entity, be it an federal, state, local agency, or some other partner in the community. This can be publicly available data that's posted online, which is the best kind. Other data can be requested, and then sometimes you also have to pay a fee to get data, unfortunately. I've got several examples here of all these different types of data. The first is our primary quantitative. So this is data that you collect yourself that is focused on numbers. So one example would be administering a survey of your contracted providers to get information about workforce diversity. You might look at your own provider data, administer a school-based survey. Those are examples of primary quantitative. These are examples of primary qualitative data. So for example, a board might do a focus group with immigrants, refugees, and migrant farm workers. They might, make sure they have someone who speaks the language of the folks in the focus group facilitating that group. And then some other examples, key informant interviews are commonly used, community forums, community conversations. And we have one example here from MHRB, Clark, Green, and Madison. So shout out to Greta, who's on the call today. They have been doing a series of community conversations and focus groups focused on the Black community in their 3 counties. And some of these, they've had some in-person events. They have had some online Zoom discussions, and it has helped them to identify what are the greatest strengths and challenges in the Black community in their 3 counties. And now they're moving forward with planning to address those challenges. So just one example of primary qualitative. And then this is secondary quantitative. I know you're all very familiar with this type of data. One clear example is suicide and overdose death data that comes from death certificates that you can get through your local health department or the Ohio Department of Health. And then there's some other examples of this type of data that you can get from other agencies and partners in the community. And then secondary qualitative. This is maybe a little less common, but this is where you might be taking like a summary of key themes from a community forum done by your local health department as part of their community health assessment or focus group by another organization. Hopefully I mentioned that we're going to give you guys these slides. I don't know if I mentioned that. We did share, we sent a PDF to Chad of these slides, so you will have them to refer to. I know I'm covering a lot of material. All right, just wanted to share a few go-to sources of data that we think are particularly valuable. We know it's challenging doing this work because you want data at the local level, right? You want county level data, and then you want to be able to disaggregate it within the county. And that can be a challenge because you're working with small numbers, and some sources you can't get that kind of data. So these are some really good sources to look to. Those vital stats data that I mentioned, so your overdose and suicide death data, that can be broken down by race, ethnicity, sex, age, education level. So there's a lot you can do with that at the local level. Emergency department visit data from your hospitals and health systems. There's some Medicaid data that can be broken out. Thinking about client surveys that are done by your providers and making sure they're including demographic information on those surveys so you can break that information out. And then, of course, work done with your local health departments and your school-based surveys. Those can often be broken out as well. So great sources to look to. Just a caution here about some of the survey data you might see out there, like the National Survey of Drug Use and Health or the Behavioral Risk Factor Surveillance Survey. These are wonderful sources of data that can help us get at some behavioral health challenges at the population level. And you can break things out with state level data. It's much more difficult to get this information broken out for different categories at your local level. Some of the bigger counties might have an easier time, but there's some things that you can do in terms of pooling your counties together, pooling years together, or even replicating the survey questions in your own community and maybe oversampling some groups. So I know Hospital Council of Northwest Ohio does a lot of survey work, for example, where they use questions from these surveys. So a few workarounds there. And then these are some go-to sources of data for social determinants of health. So obviously Census Bureau has lots of good stuff. The National Equity Atlas is a useful website because it takes census data and breaks it down at the county level and then breaks it out even further by race and income for some of its indicators. So that's a good one to check out. The Ohio Department of Health has just launched a social determinants of health dashboard that drills down at the local level. And then of course your school district report card data, they break everything out by different categories. So that's a great source. And then JFS data as well. So those are great sources for social determinants of health. And then also just want to mention your county profiles that OhioMHAS provided. Hopefully this looks familiar, and it includes some, some demographic information, employment, education, and broadband access. So that's another source of some local social determinants of health data. And in terms of qualitative methods, so we've talked about focus groups, key informant interviews. Those can be done in person or remotely. Community forums, town hall, World Cafe style events. Document review is another qualitative method that's less often used, but you could, for example, do a review of all of the tobacco-free policies or bullying policies in your school districts and identify themes and gaps. And then finally, there's some more innovative and participatory approaches. So really involving members of the community in collecting and generating data. One example here is something called photo voice. So that's where you could have young people go out and take pictures of different things in the community and then use that to facilitate a conversation. If you're interested in learning more about different qualitative methods or quantitative methods, this website is a good resource to check out. This is the County Health Rankings Action Center. And if you click on the Assess Needs and Resources, it'll take you to some technical assistance on how to do some of these different data collection methods. Okay, that was a lot. So I'm going to pause here for just a minute, and I'm not seeing any questions in the chat. If anyone wants to unmute and just ask a question, that works too. And I'll just take this moment to acknowledge that I know that many of you on the call have lots of experience with doing this work and with data collection and with assessment. Many of you have been doing this work for decades and others may be newer to it. Hopefully this is useful in terms of thinking about how to take it to the next level with building in equity in your assessments. And the next webinar we're going to do is going to be a deeper dive on some of the indicator, the standardized measurement stuff. So more to come. Okay, I'm going to keep going. All right. So now let's talk about the plan template. And these are considerations for how to embed equity throughout your planning process. This first bucket is engage, should look very similar to what I talked about in the assessment. Same idea. This is about engaging your partners, which I know you all know how to do, and then really starting to share power and inclusive decision making. The second area here is to prioritize. So use your assessment findings to identify priorities and priority populations. So, our assessment is a means to an end, right? And so looking at this disaggregated data, quantitative and qualitative, can help us to identify groups most in need. And then addressing the root causes of disparities. So thinking about what kind of upstream information have you identified in your assessment. Of course, atom boards are not alone responsible for addressing all of those upstream things like housing and transportation. But that's where those community partnerships come in. And then developing SMART objectives to monitor progress. And I'm going to say more about that in a minute. The third category here is in implementation, thinking about how we embed equity in implementation. First is tailoring for cultural and linguistic appropriateness. So as you think about policies, programs, and services, making sure that they are a good fit for the priority population, their voice is involved in that, and thinking about how things might need to be modified to make them a good fit. And finally, allocating resources to fill gaps. So thinking strategically about what would it look like if resources were allocated in the best way to meet the needs of priority populations? Where should services be located? What's the right balance to meet our SMART objectives? And here's a view from the template. This is the first place that equity comes into play in the template, where it's asking you for priority populations for the strategies in your plan. And on the right here, you see these are the same categories that we saw before in the assessment template. And it's asking you to develop SMART objectives. So these are specific, measurable, achievable, realistic, and time-bound. So meaning we have a solid indicator and a data source we know is going to be available over time. We are setting a target, saying this is where we want to get, and refer to what is the baseline. So this is what this SMART objective section looks like. The SMART objectives for priority populations is actually an optional piece in the template. So you do need to do general SMART objectives, but the SMART objectives for priority populations is an optional piece, but obviously it will strengthen your plan if you can do some of these, even if you just do 1 or 2 or 3 of these, it would be a great way to incorporate equity more strongly in your plan. So it is asking you for that, but a core part of a SMART objective is having an indicator and a data source. And you should have received from OhioMHAS the standardized indicator menu, which is an Excel sheet that lists a whole bunch of indicators and data sources. That is meant to be a reference and a tool for you. You're not required to use things necessarily from that list. You may have additional sources and indicators in your local community that you want to use, but there is some good stuff on there. So hopefully that will be useful to you as you circle in on the indicators to include in your SMART objectives. And I've got a few examples here of what SMART objectives could look like with an equity focus, with this priority population focus. So this first example, we've identified a priority population of Black residents enrolled in Medicaid. The indicator is follow-up after an emergency department visit for substance use within 7 days. So that's that HEDIS metric. The data source is Ohio Medicaid via OhioMHAS, because you can request it from OhioMHAS. And baseline year here, 2021, only 35% had a follow-up visit within 7 days. This is fictitious, by the way, it's just an example. And then maybe you set your target year as 2024 and say, we're going to move that up to at least 50%. And your target years, that will just depend on how you want to do your planning at the local level. If you want to be looking at things on an annual basis or set targets that are further out, I think there's some flexibility there for how you do that. So that's one example with an outcome. Here's another example. This one is more of an output rather than an outcome. Of course, it's fantastic if we can do outcomes, but we recognize that sometimes available and you're in a place where you need to do more of an output process kind of measure. So in this example, the priority population is children from families with low incomes. And the way we're getting at that is looking at our school district data and K through 5 buildings with 50% or more of the students are economically disadvantaged. That's just a way to zero in on a priority population. The outcome indicator here, which is actually an output, is number of students who participated in the PACS Good Behavior game. I know I saw this as an output in many of the community plans from last time around. The data source could be Educational Service Center if they're doing the training. And here we have a baseline school year where 340 students participated, and the target is by next school year to bump it up to 500 students. So just an example of how to do that. And the addition of the priority population piece is what kind of brings it to that next level to address equity. And then the final piece is another optional section of the template, which is collective impact to address the social determinants of health. So this is where those community partnerships come in to address those upstream factors. So you might identify in your assessment a whole range of social determinant of health factors like, housing and transportation and employment that are very challenging to address. And obviously you alone as an ADAM board are not responsible for fixing. But collective impact is all about partnerships and shared goals. So just two examples of what that could look like. So in this one, the outcome indicator is affordable housing units. And this is like a real data indicator that you can get from the National Low Income Housing Coalition. It's in the menu. And so we know that being homeless or living in substandard housing is not good for your mental health. And maybe you've identified in your assessment affordable housing as one of the driving social determinants of health factors in your assessment. So again, as an ADAM board, you're not responsible for completely solving this problem. So this example talks about a partnership, a coalition of different partners coming together to work on this issue. And then in this example, the outcome is chronic absenteeism. Of course, many factors contribute to chronic absenteeism, including poor mental health or substance use. And here we have another collaborative group bringing different partners together to address this issue. So in these collective impact examples, you may not be driving the bus, right? There might be some other entity in the community that's leading the coalition and you're part of it, or maybe you are leading it or co-leading it. That'll look different in different communities. And here's an example from Montgomery County. They've been doing some work with the Prevention Institute to really look upstream. So they are looking at these thrive factors, and you can see they really go upstream, and they're working on their planning in these areas now. Okay, time for more questions. I see we have a few in the chat. Yep, we will be providing the slides. Other questions? Questions, comments, feelings, ideas?
Just to provide some feedback, this is Mark Johnson from Lorain County. I appreciate the guidance, I really do, and having these slides and having this walkthrough. I think is helpful. This is my first time doing the CAP. I know it's all of our first times doing this specific CAP. This is pretty overwhelming for me, but I think this is helpful in going through it. I'm looking for that point where I feel like, oh, I've learned enough that I know how to do this, and I don't know that that's going to come prior to January. So I think this is going to be building the bike as I ride it. And I'm just saying that out loud, I think, to validate myself. And so I see some head nods, so that helps validate me as well. But I think this is great. I mean, this really is how this work should be guided and done. So this is helpful.
Yeah, the timing is challenging, I know, because all of these things that I'm talking about take time, right? And anything involving partnership and lots of different folks in the community, of course, takes time to pull together. So I think, as Haley said at the top, this idea of building capacity over time, and you do the best you can for this first one, and then it's a long-term process. And ideally, assessment is something that you have a nice long amount of time to conduct.
Yeah, and I'd like to reiterate, I know we said it in a couple of different capacities when we were talking about the assessment and the plan, is that our hope is that this is not a static product, that this is something that you continue to work with over time. So if there are if there's data or there's information that you come by or is brought to you or you've collected even after January, that you have the opportunity to be able to reinstitute that back into the plan and make modifications over the next couple of years. So we fully anticipate, or we hope that we anticipate that this is reviewed regularly by the boards and by the community. And this is something that can be modified whenever the need arises at the community level. So there's nothing to say that the plan that you submit to the Ohio Department of Mental Health and Addiction Services on January 31st can't be modified moving forward. So we do hope that this is we built something that's flexible for you to use over the next 3 years, but also know that changes can be made when, if necessary. So we work with you to be able to collect that information and collect those changes as they become apparent and when you need to make those. So there's nothing to say that what you start with or potentially what you end with in your January submission can't change over time.
And there's also, I didn't mention this, but there's an optional narrative piece in the assessment with the disparities. Each of the disparities questions has an optional narrative section. And so you can always put in there, we've identified these gaps, we missed older adults, or we haven't, adequately addressed transition age youth or LGBTQ community or something, and just you can just describe that as like an area of future, in the future we hope to address XYZ, because it's a lot.
Yes, and thank you for bringing that up too. We had our learning cohort meeting earlier this morning, and I was very kind of in inarticulate ways trying to navigate the deliverables of what we're going to learn this afternoon. And one of the conversations was about the capacity to address disparities. And then what we pointed to, and hopefully using that narrative section to be able to identify and illustrate to us what those capacity issues may be. And one thing that we want to be clear and make sure that we get our point across is that even though that we're asking you in the assessment to identify where particular disparities may be or the populations that are experiencing disparities, that doesn't mean that you have to address each of those inequities or each of those priority populations within the plan. We're not drawing a direct line from the identification of disparities to you having to address each and every single one of those in your plan. What we're hoping to do is being able to use the assessment data on a statewide kind of level to be able to analyze where disparities may be across what specific populations and in what areas. That doesn't necessarily mean that we're going to be able to address all of those as a state or as you as a board, but we're hoping to be able to collect that data, analyze that, and potentially identify resources down the road where the state may be of use to help you address these inequities moving forward, or these populations that are experiencing disparities. So we're not asking you to identify and then fix every single one of those in this plan, but hopefully take the time to identify where these disparities may exist, help us to be able to analyze that and identify some potential resources down the road where they can be put to better use.
All right, Haley, you want to
Wrap us up here.
finish us off?
Happy to do it. Thanks so much, guys, for your time and for being here. We know it's a lot of information. We hope that the slides are a resource to you, and you know that you have access to us. You can continue to come back and ask us questions and ask the OhioMHAS team questions. We want to leave you here with some next steps, including some future opportunities for TA. As you know, Chad and the OhioMHAS team are hosting office hours. Those will continue. The sessions times have been selected for the next month or so, and you should have those on your calendar, I believe. And more dates are coming after that month that's pending. In addition, we have 3 future webinars that the HPIO team will be presenting. The one in November is on the standardized indicator menu, and we're going to be doing a deep dive into some data stuff. The other December and January webinars have not had topics selected for them yet. So we would love to hear from you if there's anything in particular that you'd really like to hear us address or that you think would be helpful for us to expound on. Please go ahead and let us know that. You could type it into the chat, or you can take our survey, which we really hope that you do. You can use your phone and look at our QR code and take it on your phone right now. Chad just threw the link in the chat. You're going to get an email later with the link. So whatever is most convenient for you. We thank you in advance for doing that. This really brief survey helps us know how to produce better TA for you, and we take your feedback really seriously. So, and in that survey, we ask you what future topics we should cover in webinars. So fill that out and let us know how we can best help you in the future. I'm going to leave us with, this is Amy and my contact information. You have Chad's. If you need anything, please let us know. If you have questions after today, feel free to reach out to us. And thank you very much. That's a wrap.
All right, thank you, Amy and Haley. We do appreciate it, and being able to provide some context to some of the bigger conversations that we have had and some specificity to some of this. As I said, we are kind of inarticulately kind of talking about this over the last couple of weeks. So we do appreciate your expertise, and then also the expertise of the diversity and cultural competency work group here within the department that were able to provide some input on this as well. So thank you to that team. If there are no other questions, we will go ahead and wrap up. We do appreciate your opportunities and your time for participating this afternoon. And again, reach out to any of us if you have any questions. Until next time, I hope everyone has a great afternoon. Thank you.
Bye all.